Thank you so much. Again, thank you so much, everyone, for allowing me to come and give this talk about my unexpected path towards becoming a physician scientist and informatician. I gave it the title, Embracing Opportunity in the Midst of Uncertainty, to remind myself that some of the most transformative decisions that have led me to the career that I have right now have been associated with moments that I've decided to perceive and address particular situations not as challenges, but as opportunities for self-discovery and growth. Does this work? All right, these are my disclosures. Okay, so to know a little bit about my ambition and what drives me, you have to know a little bit about my origin. So in this picture, you can find 7 siblings. Go ahead and count them, try to find me. 1 sassy and witty grandmother, and 2 very amazing but very patient parents who were the first primary role models and mentors in my life. We are proud Colombians, having moved to the United States shortly before I was born. And in addition to a passion for great Colombian coffee and baked goods, my parents also instilled in us a passion to serve God and serve others. And we did this in a unique situation by becoming a pastoral missionary family in Houston, creating and planting churches, as little kids and into our high school and college episodes of our life in areas of underrepresented communities. And this was really a very unique situation where we were thrown into a lot of leadership positions before we thought we were ready. But it was also a great opportunity to learn how to work effectively as a team, learn the importance of co-mentorship, and also really to dream big, not only for ourselves, but for those that we serve. And when I was told my dad that I was going to give this talk, I told him, you have a lot of wisdom, Dad. What is something that I should distill on a lot of these trainees? And so he was very quick to reply back. He was like, well, just tell them what I've been telling you guys every week of your life. It's that success is really a combination of understanding and discovering your mission in life. What is that passion, that pursuit, whether spiritual or from an academic career growth, and then determining in your whole heart that you're going to pursue it and pursue it to its greatest degree. And part of that is going to be, you need to be persistent, in particular in moments of challenges. So this has really kind of led our way of life and also our way of pursuing education and another career. And a shout out to my older sister, Claudia, who became the first Hispanic female physician in our family, but also in a lot of the communities that we worked in. And that, for me, was really transformative, because then I thought, wow, this is a really wonderful way to serve others, is through an interest in science and medicine, combining those both. So why don't I just copy and paste what she does and follow her to Rice University? So she went there, my deaf brother went there, and so then I begged to get in, and I did. But I started my undergraduate training at Rice University, and it was great. I loved doing everything that was pre-medical related, also getting a BA in biochemistry. But with everything that was going on, I really thought, to be a really good candidate for medical school, I should get some research opportunities and experience under my belt. So with the help of some amazing mentors at Rice, I got into contact with Dr. Funda Merrick-Bernstam, who's a phenomenal surgeon, but also she wears a lot of leadership hats at MD Anderson, which I didn't know about because she was so humble, but she was so passionate about the impact that her translational research was having on a lot of cancer patients that I was hooked at the beginning. I was supposed to do a summer rotation with her, which led to about 2 years of work with her while I was still an undergraduate, just running across the street and hanging out in her lab. And this really led to a lot of growth and just understanding the complexity of cancer research. It also led to my first authorship paper publication, analyzing the antitumor activity of rapamycin and octreotide as single agents or in combination in neuroendocrine tumors. This was, as a trainee where you're learning a lot in your PhDs and your postdoctorate degrees, you're trying to really see the value and the impact. And I remember hanging out and just watching my Western blot process for hours, but it was really, really exciting for me because I thought this was really transformative, and I still believe it. But even on this paper, it was very interesting to see that our hypothesis failed. adding 2 different drugs, one that was supposed to inhibit the activation or the negative feedback of the first one, rapamycin, failed. And so in the midst of initial disappointment, I think it was really valuable for me to see from Funda that this was still really highly relevant research, that this was very informative for us to see that we should really seek other alternatives or understand the deeper mechanisms and really move quicker into translating this and other research mechanisms to effectively take care of our patients. So Funda became one of my primary cancer research mentors. And then there's a lot of different terms that are used to talk about mentorship. There's, just personal support, helping to set goals, and how do you measure success, and motivation. Motivation is one of the big key ones that I want to really continue to stress throughout this particular talk of mine. And so I like to kind of say that she really helped me define my mission. So what was the primary driver that I saw? And my mission was to cure cancer. And I think it's important at the beginning of where you are in your career is to keep it broad, but specific in terms of the impact, but broad in terms of how that pathway can look. And I also like to say, if people remember this whole situation of, be like Mike, such a great role model for a lot of people. I wanted to be like Funda. And so how do I become like Funda? I try to cure cancer by going to Yale and becoming a surgical oncologist. So that's where I started off. I went to Yale, and so got connected with a lot of the different surgeons. I love the technicality and the precision of surgery and just the relationships that you can create with your cancer patients. But I also told myself that, translational research was really amazing, but this is another potential opportunity to explore something new. And so that's where I decided to really get into clinical research. And Dr. Tony, he had done a lot of NCDB analysis, and I was like, this is really fascinating to figure out and understand how do you handle large cancer databases to really tackle some problems that you don't have clinical trial data related for them. And so I came in and I befriended him, and when he said, yeah, come on over, join our lab. I was kind of expecting the whole protocol workbook. Here are all the reagents. Here's how you do, specific things to not kill your cell lines like I did in a translational lab. Instead, I got, here's the data set. Here's the SAS software. Go figure out yourself and come back when you have questions, relevant questions. And I remember being like, well, this is odd. And this is not like we do in classes. But he was on to something, because after I kind of got out of that initial shock, I really developed my own pace in terms of learning, and I became addicted. It was one thing of really trying to find that mastery of learning how to code. And I had done 2, computer science courses, in my undergraduate. So this was just kind of reliving that. But really, I wanted to be so invested in knowing this cancer database, particularly in lung cancer. We were trying to figure out what was the effectiveness of several multimodal therapies, including radiation therapy at that time. And so I was going to learn how to be the best. And so sometimes that just meant, again, working on my own off hours. But this was a unique situation where my mentor was really trying to drive autonomous motivation. So what does that mean? And really that definition that's out there is that it's a drive to engage in activities out of personal interest or genuine value rather than external pressure. So it's that intrinsic motivation that you start developing as a trainee, plus an identified regulation, or you want to do it and you're driven because you find it value, you find it meaningful. And this is important because it reminded me of one of the pillars that my dad was talking about of that determination. After you find your mission, there's even a self-determination theory, which is a framework of trying to understand what really motivates us as humans and what helps us in terms of well-being. And there's 3 basic needs. One is the autonomy, having autonomy of being able to grow and develop and feel that you have a choice to be able to pursue or endorse a particular behavior, to become competent or master a particular set of skills or activities. And we all do this throughout our training. And then have relatedness. How do we connect with others? How do our skills actually help serve ourselves, our growth, but also serve other people? So it's kind of a bi-directional thing. And that all gets funneled into influencing your level of motivation, going from amotivation to controlled motivation to autonomous motivation. So this was really eye-opening for me that, yes, I can teach myself, and I can actually, in the midst of this, I developed autonomous motivation, and that actually enriched my stake in the game in the proposal. It wasn't just, come here, churn some data, some results. It was, do you understand the problem? Do you respect the significance of it? And it really allowed me to have much more rich conversations with the statistician and with Tony, because I was deeply invested in the cause. This was an interesting study that was created in terms of what motivation drives medical student learning quest. And part of what they found, they did a lot of surveys in terms of motivational questions, but for students who had high autonomous motivation, they did better in everything. They had better meaning-oriented learning, greater reflection, they performed better academically. They were also more invested in tutoring or in mentoring others compared to those who lack motivation or just had kind of controlled, I need to do this, right? So part of my self-discovery and journey was what in my mission and what is it that really drives me, and how do I have mentors that help bring that about and make me aware of it throughout my career, stages of my career. So onward, I learned a lot, mastered, the staff software, learning how to interpret SEER and NCD databases, the pros and the limitations. And then I came into residency and I did a lot of that similar extended research there. But I got to know and bond a lot with the head and neck radiation oncology team. There's some here. One of my primary mentors, Dave Fuller, who really recruited me, made me feel invested in the cause. And it was interesting that I jumped ships from surgery to radiation. How did that happen? My mentor, my surgical mentor. And in that experience actually pushed me to ask more questions of, well, what really drives you? And things that came out were like, I am very art driven. So I'm a lefty. I like that. I thought, so he was like, do a rotation radiology. I did it and I kind of fell asleep, but I loved the images. And I really needed the comedic continuity of care, but I didn't want to go into medical oncology. I wanted to stay technical. And he was like, don't tell anybody, but I would consider radiation oncology. Sorry, Tony, I'm telling people now. And his neighbor was a radiation oncologist. I ended up hanging out with them at Yale, and it really transformed my career into a totally new, different field. So I did had the opportunity to come back full circle where my original mentor, Funda, was. I did my training. I sought new opportunities. So I knew that I was really good at wanting to be efficient in clinic, right? With the EHRs, we had a massive transition into the Epic medical record system, and that was slightly chaotic at MD Anderson, but I was quite skilled in it. So I ended up being a quality improvement template documentation generator. And that was a lot of fun for me. But that was enough. I got through. I actually got hired. I was super excited. They were hiring for a full-time clinical faculty position, which means that I mainly have only time to see patients with heavy clinical load. There is a residency teaching educational component that I love. And I was like, this is perfect. This is how I'm going to serve. This is how I'm going to cure cancer as a radiation oncologist. And on the side, I'll just help my clinic be better here and there. And to my dismay, I had a fantastic colleague who was like, well, what about a formal education in clinical informatics? And so I was like, what? First of all, how dare you? I just finished 10 years of training. I don't want to do more. And the second one was, what does that even mean? I'm a little tired. This is a massive moment of transition in my life and uncertainty. And now you're throwing this out curveball on me. And the best analogy that I can think of is this situation here with Dave's face on it instead. The first one was blue pill. Remain a CFA. I don't have to deal with anything. I know it. It's safe. I trained here. It's great. I can, build many projects on the side. Or take this crazy red pill and pursue something called clinical informatics and become a physician scientist without having a PhD. Increasingly challenging because then that was adding on more time to my lack of time. And I didn't really have an idea of what that landscape would look like, right? Most of the people that I knew that had successful labs were translational science or basic science researchers, right? So what did this mean? But in pursuit of seeing things through an opportunistic lens, I said, yes, let's go for it. And I really funneled that under the pillar of persistence. This was a really challenging part in my life of being like, how is this really going to impact me? But there's questions and the mentorship of saying, does this help benefit you be better, more successful in your mission? And the long story short is yes. So I went ahead right after graduating, enrolled again into school. But heads up, I have to say this is a fantastic opportunity for people wanting to know more about informatics. You can dip your toe like I did with a certificate of 5 courses, fully online. And what I like is that you can actually take from the different research or the different tracks. So my certificate turn master's ended up being a blend of biomedical informatics and health data science and AI. So what is BMI? So this is an interdisciplinary field that studies and pursues effective uses of biomedical data, information, and knowledge to problem solve, make better decisions, and be motivated by efforts to improve human health. So holy cow, that's my mission. So it's stated there formally through the American Medical Informatics Association. So that reinforced my decision to take a leap of faith. And in that, it's really important to understand that biomedical informatics, takes from a lot of different disciplinaries. And that was really captivating for me because that allowed me to really explore different collaborations. And I really, from being a part of a family of 10, I really like that networking opportunities, even as a radiation oncologist, starting off early in my faculty career. Now, for those of you who don't really know a lot more about biomedical informatics, it's important to understand that it does not equate health informatics. It's actually more of an umbrella with various different subfields in it, and there's a fuzzy line between all of them. So a lot of molecular and cellular processing, genomic analysis, those all kind of fall into bioinformatics. One of my mentors here, Dave, does a lot of imaging informatics, deriving biomarkers from longitudinal MRI imaging. But I was interested, again, in that optimization of the clinical data for improving the personalization of our patient care. And so I started off late nights still as a CFA, and then starting classwork on my weekends. And I learned about the DIKW hierarchy. And this seems pretty self-explanatory, but it's really important to think about where I was in my career and how I was really having to do a mental transition to be successful in what I'm doing right now. So as an informaticist, you really see data. We are very rich in terms of having exponential access to data, but we're really information poor. So how do we really translate lack of uniform data to data with meaning, which is information where you can then derive truth and wise decisions from that? So as a radiation oncologist, we trained through a lot of algorithms and we learned about physiology, and I saw things very differently. But as I was training as an informaticist, I started saying, okay, well, what's an example that fits into this DIKW hierarchy? And so one of the things that we do is we see patients on a weekly basis during 6 to 7 weeks of radiation therapy, and we try to better manage their symptom burden. So I was like, okay, well, data can be 150 to 135, give it some context, that's the patient's weight. So there's knowledge there that the patient is losing weight, give it additional context of the physiological issues of the radiation, creating radiation-induced mucositis, a lot of pain, therefore the patient is not eating. What's the best decision that we have implemented now on a weekly basis is having a nutritionist also see the patient, right? So intuitively, most clinicians and all of you guys are informaticists at heart, informaticians at heart. But it's just, again, how do you see the data in a different lens? And so that was really interesting for me to start developing throughout my career and my training as an informatician. Another interesting aspect is to know about the fundamental theorem of informatics. So this is made by Charles Friedman, and it states that a person working in partnership with an information source is or should be better than the same person unassisted. And when we think about it from my department's level, technology for innovation in radiation oncology, there's a couple of things that were published as a dire need in my field. So one was to integrate all of our siloed data sources, databases, to make more effective decisions and to understand and process data better. develop tools to communicate better with between physicians and with our patients. Really, really simple things in concept, but very difficult to do in reality. And then build informatics tools to support the monitoring of the delivery of care. And number 3, which is the one that really appealed to me, was there needs to be more formal expertise in informatics among radiation oncologist professionals. So again, how do we take the people who know the field or very well and train them to create these tools and understand, develop standards for information collection and analysis. So I revised my mission again. So I will cure cancer now as a radiation oncologist and informatician. And this sounded pretty cool. So that's what really drives me. That's what really got me on with my determination. And it really helped me through a lot of highs and lows that we all naturally have in our personal and academic careers. Now, it was also very interesting in terms of, well, what do you do as an informaticist? Is to actually just query, like, what are the problems that you face, right? So this is like a very different avenue of research compared to, again, translational research related questions. And so some of the things that were coming to me as a first year from the rest of my colleagues were, hey, we need tools to enhance our communication with our dentists who always keep asking, is it safe to extract this tooth or not? Because you radiated that area and you have a high risk of bone death if I extract that. So some simple communication like that was actually really hard for us to do. Support patient symptom monitoring. So how do we actually standardize the reporting? And this was actually something that our section chief, David Rosenthal, pushed, and Brandon Gunn as well in our clinics, to at least get a paper version of a validated questionnaire to always ask the patient. But again, it wasn't being effectively used in the decision-making component of patient care. And how do we better use that data to risk stratify patients to guide our survivorship care? Other things, again, as we knew, is integrating siloed databases and harmonizing data, easier said than done, for things that have already been collected retrospectively. But then how do we also push and develop standards for prospective data reporting and collection? And then my interest currently is how do we build computer readable representation of that complex knowledge? So again, this is very different than, my husband, who's awesome in analysis, but he really handles a lot of billing data, and you can really, dollar to USD or euro, or, dollar to euro can be the same, but how complex can medical information be? Well, quite complex, and we'll get through that in a little bit. But, I was geared up, I was ready. So what's the solution? I'll do as much for free, integrate it into my heavy clinical teaching activities, which is something that, you think about in your naive thoughts. Or you pursue opportunities to protect time to grow, again, continually grow and fund research to solve these problems as junior faculty, and hence my introduction to the NIHK and our grants. So again, you're going to see this guy's face popping up a lot of times. He's not evil, but he is our genius who helps us figure out how to leverage grant funding to do whatever we want. No kidding. But to really grow and push the boundaries of current care. So the case series, I'll talk about this briefly in terms of our time. But this is a career development award. Again, I did not know about this because I was not in the realm of MD, PhDing it all my life, and I didn't know any of this. So this was really important for my exposure with my mentor to tell me, hey, there are these awards. There's actually multiple different ones that you should look at, but in particularly the K series protects time and allows about 3 to 5 years for you to develop, particular skill sets that will bridge you to becoming an independent research investigator. So taking you out of the clinical faculty appointment to potential research faculty appointment, but explicitly requires the guidance of experienced mentor or mentors. This is another one that a lot of people have probably seen in our lab, but depending on where you are right now, there are available grants to help you get money to learn about anything you want. This is the perfect time to be able to do that. But in my particular moment of transition and uncertainty, I was around here, early stage of faculty. So I was told, the K-12 and the K-01 are great mechanisms. It's tough to decide which one, apply to both. So that was a very interesting thing that I was tackling while I was also trying to figure out how to write and sign prescriptions as faculty. So what is a KO1? So just a quick overview in terms of the breakdowns. It requires a commitment about 75% of your time, or 9 months, to really throughout the time of the grant, 3 to 5 years, to train in something new. So I already had that down, clinical informatics. I was already signed up to do the certificate. I was just going to push it out to a master's. And sometimes also to increase the research workforce diversity. So I was lucky enough to be funded under a diversity-related grant as a female Hispanic wanting to be a physician scientist. This is actually the current funding announcement for the KO1, and there's several different institutes. We decided to reach out to NIDCR that focuses on dental cranial research. So as a head and neck radiation oncologist, that was we had a lot in common in terms of research initiatives and desires. But as a candidate, these are the things that you have to think about if you want, and you think, okay, well, how hard can it be? So you have to talk about your background. What's your commitment to healthcare research? What's your potential to develop, right, as an independent investigator? Talk about your career goals and your progression. Have a formal career development plan. And so what does the timeline look like for the next 3 to 5 years? Build a research strategy, have multiple or single co-mentors, then they have to sign everything. And then the institution also has to sign off on this KO1 initiative. I was reading a little bit more, and it's probably not a good thing to read, when you're really sleep deprived. But then I read it's 12 pages, and I was like, I don't have 12 pages worth of things to say about myself, and I'm not really creative in knowing what type of career to define in clinical informatics, because I haven't seen anyone else have a lab in it. So it's really kind of a vague scenario for me. But enter this guy again with his opinions, and he was like, it's not that much, actually. Here's how you strategize this breakdown. So again, you're going to have these highs and lows, but this is the important and the value of seeking, really effective mentors to inspire you to really push your own boundaries. So we started working on it. So what was my goal? And what I really quickly realized I needed to loop back my mission. What did I want to do? I wanted to be an example to a lot of minorities that this can be possible. You can come into this, and you can come from it from a very unique track as an MD only. And the nice thing is that there's a mentorship aim as well. And I wanted to pay it forward how I was actually seeing a lot of the mentors spend their time and energy on my development. From that, again, having really good mentors discuss areas of need and how they aligned with my potential interests was, okay, where do we want to grow? To deal with the need for symptom monitoring translation into our EHR system, you need to learn about implementation science. And I was like, cool, all right, let's make that a goal. Another one was we need to learn about, there's a landscape on dental informatics. I know a guy, so sure, let's do another goal. And then we want to create prediction models, which I thought was really interesting from the data. And then something that I was unaware of, but you really want to be explicit of, is you should also explicitly mention a professional and leadership growth track or goal. So that seemed pretty nice. It made it seem less, demystified it and made it seem less crazy. But figures are the way to talk on grants. And so this was really helpful for me to say, oh, okay, I actually have things that I've done. And just, I can translate it into goals, and you just translate those goals into specific games. So you're really not coming up with multiple new novel ideas. You're just saying it in different ways to satisfy a grant need. And then how do you transition this into an R01? So that was a really unique opportunity that even if I hadn't gotten this grant, it was so valuable for me just to understand the process and really, appreciative of that opportunity, not only from Dave, but other co-mentors who share their own grants, because it is a collaborative framework. Everyone kind of learns from their predecessors as well. In terms of the timeline, Gantt charts. Very easy to start processing things. Okay, now we translate those goals. We specify a breakdown of your specific aims that are associated, and in each of those goals, you then add formal classwork that you're actually already doing and you would have done without the career academic part. And one of the things that was really helpful is as I was like listing these different goals, my primary mentor, Dave, was connecting me to a phenomenal mentor network, including Elmer Bernstam, who's here as well. So I appreciate that. So all of this was something I would have never done, right? In the CFA track, I would have never gotten to meet these people. I would have never gotten to meet their network of people. And it was fantastic to know. And I think as a trainee, it's important to step back and see, like, we're really scared in communicating with people we don't know. I remember getting somewhat yelled at because I was like, ooh, that person never emailed me back. So I'm just, I guess I'll email them one more time instead of trying to text or call or meet them in person. But, you know, people like Mohammed Walji, it was fantastic. He just popped up on Zoom. He's like, yeah, I'll support you. I don't know who you are, but let's do this. We have the same mission. So again, that's the thing is, a lot of the growth, a lot of this uncertainties, it led to this really transformative world that I didn't even know existed, where there's a lot of collaborations, again, because what is truly valuable is creating really strong and meaningful team science related projects to solve complex cases. And just a brief segment or interlude in terms of why mentors matter. This was an interesting paper that was published several years ago in 2013, and there's being updated right now. But this was just serving a couple of, I think 150, 160 radiation oncologists, with some of them, about 96 of them having a mentor and 60 of them not having mentors. And there was a significant difference. The number of citations, the citation impact, the number of respondents receiving NIH funding, that was 28% with those with mentors compared to 16 that didn't. And then the time allocation, that protected time that they had to grow and then publish more and then submit more grants. So it's actually like a continuous cycle where all of this was really initiated and associated with having a good mentor. So again, in summary, great mentors, in my mind, inform and encourage you to consider opportunities for growth. And I really want to pause there and say these can often look like something that's going to take a lot of time. And it can look like a challenge. But I encourage you guys to, again, think about, does this opportunity align with my mission or not? And if it does in some capacity, I think there's always some form of benefit of learning from it, or even failing your way through success. You learn from a failed or rejected grant. Okay, so back to my research itself. Okay, so our research strategy was to convert our problems into aims. So nailed it. We decided to do an interrupted time series, pre and post implementation pilot program of launching our Midazi head and neck pain symptom module into the EHR system. We were going to translate 3-dimensional radiation dose volume onto a 2-dimensional picture of teeth that dentists train and know how to interpret, and then create machine learning models. So after what felt like an eternity, I submitted the KO1 and I felt so impressed with myself. I was like, man, I did it, and time for a break. No. So if you're around the right people, they will do this to you. They'll be like, pop a champagne, there he is laughing over there. When's the next one coming out? So this happened. Again, never in my lifetime would I have been there saying, Amy, you're gonna be that girl who writes multiple grants, and even if they get rejected, you'll rewrite them. But the reason that happened was you are who you hang out with, right? So I did it so much when I was at Rice, just being that infectious vibe of all the interesting things that my friends were doing. Same thing in residency and medical school, same thing in your career. So be around people who are like-minded or people who you aspire to be like, right? For the most part, they will show you how to play the game. So I had a lot of rejections, but I had a lot of crazy success also, to the point that there was a point where, like, hey, you have too much money and too much time. We're going to have to figure out how to do this. And another interesting component, in transition through all of this has been, learning how to write grants, not on my own, because I don't have the world's most interesting thoughts and ideas, but is to co-write grants. So someone wise once said, it's half the work and twice the fun. So through all of this, I went from, again, just being really passionate about patient care, but then really seeing myself as a capable physician scientist, and now really wanting to become key personnel, multiple grants, to be a rad-onc, an informaticist, an implementation science expert, or TBD, because there's more grants in the pipeline, and we'll see how that goes. But again, it's all about your metrics of success depends on how much you actually try in the first place. So with each of those failed, submissions, I always learned from each of them. And it was always an opportunity to collaborate with new people that I now have long-lasting relationships with. So somehow, all of my career, I was like, well, dang, this all keeps going back to my dad's like little triad of what success really means and what drives my success and how do I perceive myself. Because I think one thing for a lot of minorities, and I don't know about the women out there for sure, is that I always keep pushing the boundary of success. So when I finally reach a valuable milestone, I now am comparing myself to where I should be in the next milestone. So it's really important to embrace where you are and see that it is valuable and you're being successful. But a lot of that autonomous motivation really comes to making sure that you understand and you're pushing for this mission that you will figure out over time. But it may change from what you think it is right now. So again, be open to different possibilities and opportunities. All right, so really briefly in the next minutes, talking a little bit about the actual research that I've been doing. So back to the issue of patient symptom monitors or patient-reported outcomes. There's a lot of stuff in the literature talking about how great it is for monitoring patients, helping patient safety, care coordination, and delivery of personalized care. There's really interesting studies of why does this matter, this data coming from patients, where apparently we, as physicians, sometimes sadly underrecognize these symptoms. And we also underrecognize it in minorities, like in young patients, in Black patients or other races, or even in males here that had breast cancer compared to their female companions. So at one point in this study, about 53% of under-recognition of one or more symptoms was identified. So again, PROs matter. They're associated with decreased ER admissions, improved survival, and this is actually from what our Madazi head and neck symptom profile looks like, is multiple cancer and non-cancer specific and symptom interference questions. And you can see throughout 6 to 7 weeks of radiation therapy, most symptoms keep getting worse. And if you get concurrent chemoradiation, it's even worse for you. So again, how do we become proactive instead of reactive in our clinical decision making? So this was really important for us to be able to implement PROs in our clinical practice and not just have it for research purposes. But how hard can it be? So back to this question. Very hard. So there's a lot of barriers that have been reported, having financial, IT resources, understanding and involving actual stakeholders, changing behaviors for implementing standards, physical spaces for PROs. So instead of, through this whole mission, and again, there's a lot of autonomous motivation to figure out, well, how do I do this? And I know I can seek particular mentors like Kate Hutchinson or David Rosenthal to tell me, where to lead me to next. I felt like when I was reading the literature, it looked like this seamless roadmap. I got money to do this study. I measured the effectiveness, but I don't know if it got institutionalized. What I wanted to see was something more like this. So I developed it as part of the KA application. And this for me just makes more sense. It's actually, okay, how do we implement it, but then simultaneously always continually evaluate it? How do we set that framework up in the information framework? Because all the other studies were just looking at it from a predefined time snap, but we wanted scalability and endurance in this process. So in comes some information on implementation frameworks, including REAIM. This has 5 different domains to assess. Nola Proctor also has some interesting outcomes, including like acceptability of your implementation, feasibility, fidelity. And so these are all things that I was really excited to learn about and spearhead. So even though I had only read about it 24 hours before, I was apparently the lead and the expert in my section. So it just felt really weird, but that's how life goes. So you just kind of keep walking and persevering, and you just need to be ahead of the game just by a couple of hours. The other thing is stakeholder engagement, which I found was a big issue in a lot of studies. So I was like, okay, I'm going to really identify what this means. And so part of it is just, again, building those resources, creating trust in the partnership, because a lot of issues was, okay, well, where did it fail? You know, it's the nurse didn't figure it out, the medical assistant didn't pull, the physician's too lazy to report something. So actually learning from other people's trials and errors was a way that we built ours to be more successful, but it still has its own challenges. But again, teamwork is so important in a lot of the different projects, especially for in informatics. I'm not going to belabor this, but the Patient-Centered Outcomes Research Institute has a ton of resources for anyone interested in learning about stakeholder engagement. They even have a plan template if you guys do implementation programs. So for us, I want to make sure that I survey our patients and our providers. We develop research educational resources, again, to share the vision, share the mission, and engage with our patients to make sure that we get the compliance with actually filling it out. So part of it is, can you find the survey to fill it out? And physicians, can you help them figure it out? And will you actually use it, right? So all of this sounds easy in theory, but it's actually really challenging because it's associated with behavioral change. Another cool thing about implementation or pre-implementation pilots is like, well, how good is our current system of using papers? We were really proud of it because it was every patient, every visit. But then I found out that it actually then gets sent to a nurse who then sends it to another department who then is supposed to upload it as a PDF file somewhere buried in the EHR. But when we tried to look at the previous 6 months before the implementation, only 8% of the paper forms actually were uploaded. So this was really helpful to show there was low stakes, but then it also raised the energy to really implement this and pilot it. So as you can see, we actually had tremendous growth in 2023. Before that, actually, COVID happened. That was unexpected. We lost a lot of coverage, a lot of the framework that we had, but it was a really nice now re-aim framework implementation data collection of like, hey, if you just build this in the system, how many patients actually see it and do it without telling you? Surprisingly, about 45% of them do. But you can see that once we actually created a formal plan for it, we had about a 30% median increase in adoption, and we also have about a 4-fold increase the several months after that. And what did that cycle require? It was a lot of, again, stakeholder engagement, building tools. So this is for the patient. This was already created through our EHR, but the other ones was informing and building these templates for the schedulers. Okay, they need to know, did the patient fill it out or not? So now you have a way of figuring it out, and now we integrate. If they haven't assigned one, you approach them and say, hey, at time of check-in, please complete it. We have things for nursing and medical assistants to enter it in. My favorite is the synopsis window. So it's all about the proximity principle. I'm going to use that data more for my decision-making if it's proximal to other data that's relevant, like their weight, right? Are they getting hypostatic, are they getting orthostatic? Are they showing a physiologic decline because they're losing weight? So this is an example of a patient that during radiation, their pain significantly peaks and you see drops of weight, but during the follow-up period, you're seeing that offset and recovery. So this was really exciting to be able to then not only use these data elements as secondary structured data for predictive models, but then actually use it for clinical decision-making for each patient. Additional tools, and this was for the implementation, so that other half cycle, how do we help implement it? And then again, this was an unanticipated drop or change in our clinical space, but we actually found out about this before the monthly report because our stakeholders, our medical assistants told me about an issue. And so this is, again, the success of the cycle maintaining itself with everyone being part of the mission to actually provide and complete these PROs because they help improve our patient care. And it's just an example of how some of these tools allow us to see, is our method really important? And yes, this is actually another clinic who deployed the same PRO, but they don't have anyone overseeing it like me. Okay, So developing other standards. So not much time to talk about this, but this is the fun stuff for informatics. So particular question of what is ORN, nobody knows. So apparently there was over 16 classification systems, over 9 definitions. So that really didn't allow for data harmonization. And even in the onset of a new risk-based classification model that integrated clinical data. So we ran a Delphi model. Let's get a room of 70 experts together to figure this out. Let's just first figure out, can they use the existing systems? Where are the gaps in the information needs? And it was very apparent that these are 3 cases of mild to intermediate to advanced osteoarterial necrosis. And only the 3rd case can people mostly have high agreement in saying this is a bad case of ORN. But the other 2 cases, there's a lot of purple bars, high bars, and that meant that they were unable to classify the patient with that staging system. So again, really a big issue. These were some of the surveys that we deployed, again, trying to just process personal use and the utility of existing systems, how to better differentiate, is there a time bias when we try to incorporate a time variable in the definition of ORN? So again, a lot of nuances of the knowledge. We didn't, fully, solve everything, but what we were able to do was to create 10 consensus statements and 9 atomic data elements that should be promoted in prospective cancer data research so that I can actually translate that easy. So your understanding of a ClinRad model at stage 2, well, that was developed based on these subatomic elements that are very clear, should be a lot clearer to process, and are also interoperable from a machine standard. And so that leads to really the development of ontological systems. What are they? They're everywhere. So there's a lot of different standards like the International Classification of Diseases, SNOMED, LOINC, and then a lot of the other ones are how do we create formalizations of concepts and then relate those concepts together with unique identifiers to then create interesting analytical capabilities using ontological systems. So this was a publication that I was excited to be a part of, which is looking at building the first operational ontology for oncology, trying to explicitly express key data elements in radiation oncology, symptom, toxicities, monitoring, but there's still a lot of room for growth. And with that, I'm going to skip through some of the models, but again, this is just an example of our awesome work with my colleagues, Humbert Vidan, Mohammed Nasser, and Sana Van Dyke, which was, what is a simple question? We need tooth-level dose data, but manual segmentation is too tedious and time-consuming. Can we auto-segment this issue? The answer is yes. This is a really great, phenomenal 2-phase deep learning model that was developed. So now we can automatically extract that data and report it. But the dentists don't get it. So how do we communicate in a way that the dentist can communicate it? So this was another sub-1 of actually using an angular ray-based segmentation of our jaw to get tooth-level data. And it was great to see that even though you can manually adjust the auto segmentation of the rays, the fully automatic system does pretty well in comparison to Gold Truth. But what is the clinical translational impact? It's this. We have auto segmentation models for the whole mandible, and that's what a lot of our toxicity prediction models have been built on. But as you can see here, the maximum dose doesn't really differentiate between a small cohort of non-ORN and ORN cases. But if you take any of these sub-level, sub-segment jaw, tooth-level based dosimetric data, it actually differentiates a lot more. So we're really excited to see how this will improve our spatial localization and risk detection of osteoarterial necrosis. I'm going to skip this for this time being. And again, all of that has fed into this awesome R01 joint data science venture with Princess Margaret Hospital. And I'd like to take a minute right quick to just talk about leadership, especially because everyone in this room can be an effective leader even today where they are. There's a lot of characteristics of leaders, but this is what I always think about in my perfectionist instinct is I'm unprepared, it'll be challenging, too many uncertainties, maybe later. And then these are your mentors. Go, you got this. I nominated you, smiley face. You're ready, and we'll be here to support you. So again, what did that lead to? It led to all of these unique experiences where I've, again, networking and just a lot of growth and better ways of being able to tackle my mission in life. And these are the take-home points. Any questions?
Thank you, Dr. Moreno, for this talk. Does anyone have any questions? If you do, please raise your hands. Okay, I'll have a question. You talked a lot about motivation, and as one of the major uh, things that motivated you through your career, was there a time in your career where your focus shift from struggling to I got this? And you talked a lot about your K awards, and you had some rejections, and did those impact your motivation, and how did you overcome those?
Yeah, I'll be honest. It still happens to this day. You almost feel like you're bipolar. One day you're like, I've got this. It's great. Another day you didn't sleep because you had, 3 different cases to take care of. There's personal issue, your baby's sick, and then you're like, I don't got this. So it's a reality that happens over time. But it's one where I think what was really valuable, even, this past week is, to be able to take a pause. That even though there's a lot of motivation. Some of my biggest challenges is the drive and not feeling like I'm accomplishing enough. There's no one other, around me that's telling me that I'm not doing enough, right? So sometimes I'm motivating myself too much, and you have to focus back on priorities, make sure that you're taking care of yourself, taking care of your family. But I think for me, it's the atmosphere of having still those supportive mentors that I can just go and vent to and be like, hey, this is normal. This is totally a normal feeling, even if you don't get anything done because you just came out of, having a baby. It's fine. And so I think it shows and demonstrates that the mentorship doesn't just end after you finish the postdoc. I really do encourage you guys to continue those mentorships for lifelong, friendships. And think about it also when you are trying to train other, mentor other trainees that they're probably going through something similar, but are trying to really impress us. How do we balance that need to grow, but also need to take breaks here and there?
Hi, thank you for your talk. I was just curious along the lines of the keeping the mentorship going.
Uh-huh.
Do you have any advice for, continuing to foster the relationships with your previous mentors? I'm a postdoc at Baylor, and I find that, as I keep going, the only times I talk to people in grad school are when I need something from them.
Yeah.
That feels kind of bad. So do you have advice on that?
Yeah, I think what's really worked effectively with me in my personal one is to just give them like updates in your life, right? So for some in particular, if I got a new grant, even if they weren't part of it, I'll be like, hey, I got this new grant. I just want to again, thank you that this wasn't possible without you like helping inspire me to get into that pathway. I hope you're doing well, right? So sometimes it's just having those touch bases where you're asking for nothing, but expressing gratitude for what they've given, that you actually foster more of that friendship that goes beyond just the platonic give and take of data and resources. That's a really valuable question. I think the other one that sometimes I struggled with for a long time and now I'm working on is how do I seek new mentors, right? So also like I'm a postdoc, I'm a CFA that doesn't might not be as cool in data science, but it's again being open. You'd be surprised that a lot more people are interested in finding like-minded people, right? So I'm much more interested in training, mentoring a trainee who reaches out to me and says, hey, I read your lab website. I think this is really cool. Can I sit down and talk to you? There's much more of a connection there than saying, expecting someone else to make those for you. So you'll have mentors that will guide you with some of the networking, but then as you transition out of a postdoc or a fellowship, it's okay, how do I expand my network now to, become more effective in my own mission?
I have one more question since we have 5 minutes. Dr. Moreno, you work with large language models, and can you just tell us a little more about how large language models are going to change the future of healthcare, and just briefly, as I know it's a very interesting topic.
That's a loaded topic. But I think, it's already affecting, I think for the most part, there's a lot of task efficiencies, stuff that could take a lot, like writing letters or whatnot. It can be facilitated. There's a lot of education, aspects of patient education, personalizing that. I think the true integration into clinical decision support tools might take a little bit more time, because that's a question of what is the functionality that you're seeking of the LLM. Is it a life-altering, clinical decision support, or is it more just information, providing some information that's not, life-altering, right? So there's a severity. The other thing is, how do we ensure that we address a potential bias, right? So there's a lot of bias in how these were pre-trained. So if you're trying to implement it into a scenario where there's largely underrepresented populations, is it going to be biased towards those patients? So those things are things that are still actively need to be managed, as well as how do you update it, right? Because the knowledge, cancer discoveries, and the treatment approaches are just changing so much. I think this is where, digital twins is going to be a really interesting, component, but also creating these frameworks where the LLMs learn from each other and we have the human in the loop. So I think it is here to stay, but there's a lot of room in terms of how fully integrated it'll become.
Thank you.
Yeah.
I feel like that's time rather than being like a very written out roadmap for people with different things to do at different times. Have you ever seen such a document generated by any of your early mentors?
Yeah, that one over there. Well, no, not so much do this, do that. I think it was more of here is what everyone sees. I think that was really valuable for me. We joke about creating a lecture of failing your way into success, because what people see on social media or what people see on your CV is the 5 to 10 grants you received, and then I love that he switches to a slide where it's and then these are the 30 that I got rejected. So part of it is that transparency. In terms of where you are in your career, I think that the NIH related slide of saying if you're at this part, the T32, the K99, series, or the K01, those are kind of well structured because they have some prerequisites. And so what was helpful is to even know that those existed at those particular time points. So I think those were probably the most preset for me. And then I just learned to say yes to these opportunities. I can't tell you how many times a lot of my mentors just send me emails, be like, apply to this, apply to this, apply to this. And I'm like, all right, let's do it. The other thing that I want to advocate for is the other thing that scared me was I don't generate, novel ideas on the fly all the time. If I get 30 different grants, but the reality is that you don't have to, right? It's modifications of what you've learned or integration with someone else's domain of expertise and then testing that hypothesis, right? So you can generate multiple grants simultaneously. You just send them to different mechanisms that are emphasizing different aspects. So my R01 was very data science driven, but it's very much closely associated with a lot of the aims that one of my colleagues has, which is more biomarker driven for survivorship. So there's a lot of these intricacies, these nuances that the particular niches of people know because you're in that pool constantly. And so I think that's where having those mentors really makes a translational impact on the opportunities. But then ultimately it's up to you to decide to figure out if you wanted it or not, right? Yeah.
We have quite a few questions on the chat, so I'm going to read a couple of them and you can decide which one you want to answer since we're almost out of time. So the one question is, what was one thing which a mentor taught you which you will use in the future with your other mentees? And the other question is, do you have any tips on how to find other data science informatic mentors? I find that university and centers tend to organize research not by their approach, but by the system they study.
Yeah. So in terms of the first question, I think remembering where your mentor, your trainee is, and having a sense of community. I think that was something that was important, in our upbringing as a family and planting churches. The same is true for your trainees, because if you see the self-determination, it's really driven by feeling related and having that relatedness. So sometimes I had experiences where I was just really isolated with just one mentor. But I like the experiences of like having lab days, right? Where we all talk, we get to know each other, right? And we all work on the same aims. And then we figure out from there, how do we actually feed these objectives to each of our projects? So I think that's something, fostering that collaboration actually drives more of that autonomous motivation from what I've seen. And I would want to continue that as a mentor. The second question in terms of resources, I think this is a perfect example where the consortium can actually come into play. I know that there's a lot of different avenues, or like listservs, or different groups that might be available in different locations. At MD Anderson, we have the Institute for Data Science and Oncology that now has focus area forums that a lot of trainees, I encourage the fellows to go and ask questions and then network at those services as well. So it might be also as easy as finding one single person and asking them, hey, what resources do you use? So that's what I would encourage.
Okay. Thank you. If your questions were not answered, you can reach out to Dr. Moreno directly. And with that, please give Dr. Moreno a round of applause. Thank you.
Thank you.